In this module, we will discuss thoracic exercise. Our objectives today are to discuss the importance of an exercise program for those with thorax pain and/or dysfunction, utilize principles of regional interdependence to create an exercise program for those with thorax pain and dysfunction, respect the difference between active and passive insufficiency, and create unique exercise prescriptions specific to the patient, and choose or create appropriate exercise or exercises for patients with both primary thoracic spine pain and as part of a regional interdependence plan of care. A great piece was published in Manual Therapy regarding our lack of knowledge yet increased attention to the thoracic spine. Despite using interventions directed toward this region with the goal of improving pain syndromes in other regions, we do not have a standardized way to evaluate and treat primary pain here. No clinical prediction rule, clinical practice guidelines, nor treatment-based classification system exists for this region. That said, thanks to the notion of regional interdependence, attention toward this region is increasing. If we are seeing benefit to passive interventions for these regions, we have reason to believe active interventions can be equally as beneficial and possibly even preventative of reoccurrence or even initial occurrence for both pain primarily in the thoracic spine and remotely. When we look strictly at the biomechanics, we have reason to believe that improvement in the mobility of the thoracic spine will also help improved mobility of the cervical spine. When the cervical spine moves in any plane, the thoracic spine also moves, and it has been reported that up to 30% of cervical spine movement actually comes from the thoracic spine. Looking into more muscle activation, we already know that the activation of the scapulothoracic muscles will assist in improved posture and better joint loading. Looking at the most recent clinical practice guidelines, it is strongly recommended that we include exercise for the scapulothoracic region in most, if not all, patients with neck pain, regardless of the category they fit in. We also see benefits for thoracic spine interventions, including exercise in those with shoulder pain. For normal overhead motion, the thoracic spine must move in all planes. A good way to think about this is Shirley Sarman's term, relative flexibility. Our body is going to move in the path of least resistance. So the stiffer the thoracic spine, the more demand for mobility in the shoulder, which may create wear and tear. Outside of theory, we have evidence for the use of thoracic interventions for shoulder pain. Tate wrote a wonderful case series which included thoracic self-mobility for those with subacromial impingement. Minkin et al., in assessing the validity of a clinical prediction rule, found that most people who received thoracic intervention benefited regardless of meeting the rule or not. I believe that if we are to provide passive intervention to a region, we should give the patient an active way to perform mobility and activation into the new range at home. Moving inferior to the thoracic spine, we have the lumbar spine. Again, looking at the mechanics, we have the notion of relative flexibility. For example, if we are moving into spinal extension and our thoracic spine is hypomobile into extension, our lumbar spine may move more than it should, creating a possibility for pain and overuse. Rotation is another common plane to see compensation for a hypomobile thoracic spine. It may actually result in overuse of the hip. Most of the rotation should come from the thoracic spine. If not, the demand moves down to the lumbar spine and hips. Looking at somatic referral patterns in the image on the upper right, we see dysfunction in the thoracic spine may create a pain pattern in the low back as well as hips. Looking into the evidence, it is scarce and of low levels. However, some case studies and case series show benefit for addition of thoracic mobilization and exercise for low back pain. Again, we have limited rules and principles specific to the thoracic spine, so we can use these listed general guidelines. Acutely, we need to achieve the goal of decreased pain, decreased inflammation, decreased muscle spasm by educating on soft tissue mobilization. We need to teach active assistive range of motion and active range of motion to restore mobility. We need to issue PNF patterns and gentle muscle activation to restore neuromuscular control and postural stability. And finally, we need to address correct breathing mechanics. Progressing into the functional phase, we may continue with active range of motion and possibly even add resistance. We also need to incorporate the lumbar and/or cervical postural muscles for dynamic control of the entire spine, as well as integrating lower and upper extremities to restore complete functional movement patterns. We will now briefly discuss scoliosis. You will go into more detail in an upcoming semester discussing pediatric musculoskeletal pathology. When making the decision for conservative management versus operative management of a patient with scoliosis, we use an angle you see here called the Cobb angle. If that curve is less than 25 degrees in a skeletally immature patient, we will monitor that patient very closely. If the curve is greater than 25 degrees in a skeletally immature patient, we will monitor a little more closely. If we see the curve changing by 10 degrees, we will issue a brace to be worn daily. If we see a curve over 30 degrees, we will also brace. If that curve unfortunately progresses to greater than 40 degrees, surgical stabilization is often selected. To diagnose an individual with scoliosis, we need to look at the spine in all three planes, as well as use our palpation skills. Some individuals will lose their curvature when flexing the spine, and this is called functional scoliosis. Those who maintain the curve with a forward flexion, where you see a rib hump, have structural scoliosis. Also, when evaluating these patients, please look at leg lengths, measure muscle lengths, and be sure to assess muscle strength in the shoulder girdle, trunk, and hips on each side. We can use core performance tests such as planks, plank reaching, and side planks. We also need to assess rib mobility, especially during respiration. The picture you see on the lower right is a scoliometer. You will get more exposure to this device to measure Cobb angle in a future semester. Treatment of a functional scoliosis is finding the underlying cause, for example, muscle length and strength impairments. Our goal with scoliosis begins with education. Many, unfortunately, equate scoliosis with a lifetime of dysfunction and pain, which is not the case. The importance of maintenance exercise may be at the forefront of your education. You also need to educate your patient on posture and proper breathing patterns. Balancing strength, motor control, flexibility, and joint mobility is also of utmost importance. A specific method used to treat individuals with scoliosis originated in the 1920s called the Schroth method. It is a technique system which uses isometrics and other exercises to strengthen or lengthen asymmetrical muscles in a scoliotic body. Its goals are to halt the progression of abnormal spinal curvature and, in best cases, reverse the curves. With this method, we think in all three dimensions. It uses mirrors, chairs, balls, poles, step stools, bolsters, foam rollers, tubes, towels, rice bags, wall bars, and hands as tools. Here's a photo of a woman performing exercise inspired by the Schroth method. The first principle is axial elongation via the use of the bars. Then you attempt to correct the sagittal deformities. Then derotation via pulling down on a bar unilaterally or rotating in the pelvis. Then use the entire thorax for breathing, especially breathing into the concavity. You may then perform isometric contractions of the core, gluteals, and periscapular muscles for stabilization in that position. This method works on the principles of improving flexibility at the ape of the curve, both actively and passively. It uses rib and fascia mobilization, thoracic mobilization of the weak side, and lumbar and diaphragm mobilization. Honing in on the breathing correction, you may think about it as the convexity being fixed in a position of inhalation and the concavity being fixed into expiration. To correct, our hands will be placed in the concavities to facilitate breaths into that space with a quick stretch in 3 dimensions of medial, anterior, and inferior. Use verbal cues to encourage the movement of the ribs into the side, back, and upward direction. This is a picture of a home exercise program. The patient has a band or sheet in the concavities, which she is breathing into. We will discuss this specific exercise in lab. This is a written description for the prior exercise. Studies on this method have found success in increasing rib mobility, strength of the diaphragm and intercostal muscles, cardiovascular endurance, vital capacity, and breathing function, and found a decrease in pulse rate with increased effort. We will now move on to guiding principles of thoracic exercise. I want to start with a thought which may be intuitive to most of you in other joint regions. However, I see it missed in regards to the thoracic spine a lot. When we assess thoracic active rotation and then add passive overpressure, we need to assess how much difference there is between the two. If someone can rotate 30 degrees actively, but then you can rotate them 10 or more degrees past 30, the issue may not be with passive stiffness, but rather muscle coordination and firing and the ability to actively get them to their end range. Our treatments must then match their impairment. We should not give strictly self-mobilization in this case, but rather encourage muscle contraction throughout the range. In observing the differences in these two pictures, one has a band and one does not. The image on the left may address passive insufficiency, while that on the right more active insufficiency. We have already discussed the notion of regional interdependence in regards to the thoracic spine and lumbar spine, in that mobilization of the thoracic spine assists in lumbar spine pain. The reverse relationship is true in that addressing the spine stabilizers, as we learned in MSK1, can affect both the position of the thoracic spine and also the performance of its muscular system. So what guides your exercise selection in those with both primary thoracic spine pain and those where you are addressing the thoracic spine for regions of interdependence? One guiding principle is that if you are going to perform a passive mobility intervention, it would behoove you to choose a self-mobilization strategy for home. It is also beneficial to not stop there, but to also encourage active and/or resisted contraction throughout that plane of motion, and then use that motion in functional tasks. Another principle is to promote the balance of scapular stabilizers. Oftentimes, we can develop pain in overused muscles. If we find pain in a muscle of the thorax, for example, the rhomboids, then we must develop a strength program around that muscle in both the agonist and antagonist to allow for that muscle to relax. For this case, it would be the middle and lower trapezius, as well as the serratus anterior. And for that same reason, we want to promote balance of both length and strength of the anterior and posterior muscles. If we only issue mobility for spine extension, but do not encourage pectoralis lengthening, full motion of extension may never be restored. Also, if a patient only trains muscles on the front side and neglects those on the posterior, pain patterns may also occur, and balance needs to be restored. On this slide, you will see common mistakes I see patients make when performing exercise. The first is compensatory movement in the cervical and lumbar spine. You can refer to the exercises in the YouTube channel to observe this mistake. Another is they do not consider the other side of the joint. As in the example on the prior slide, to allow for full thoracic extension, we need length from our pectoralis muscles. And finally, also mentioned in the other slide, I see patients foam rolling into extension, however, never activating their extensors to maintain that new range gained. The following slides are examples of exercises, both mobilization and activation, for each plane of motion available for the thoracic spine. These exercises will be practiced in lab and can be viewed on the YouTube channel. Thank you for your time and attention throughout this module. We will get to put the principles into practice in lab.